Ladies and gentlemen, it is my pleasure to welcome you to today's webinar, Mental Health Care Navigation for Primary Care with Clinicom. And it's my pleasure to introduce our distinguished speaker, Mr. Ignacio Handel. As the CEO of Clinicom Healthcare, Mr. Handel has made significant contributions to the field of clinical research and healthcare technology. His extensive experience spans over 2 decades, during which he has led numerous FDA phase 1, 2, and 3 studies in pharmaceuticals and devices. His efforts have been instrumental in bringing a variety of drugs and devices to market, positively impacting the lives of millions of patients globally. Mr. Handel has been honored with the prestigious Christine Pierre Clinical Trials Lifetime Achievement Award, a testament to his exceptional work in clinical research. Before his current role as CEO in Clinicom, he was instrumental in founding and developing 2 nationally recognized U.S. clinical research centers. His expertise and vision have been vital in the inception and development of Clinicom, a groundbreaking technology in mental health assessment and management. Please join me in welcoming Mr. Ignacio Handel.
Thank you, Marcus. I hope everybody's having a wonderful day. I'm excited to share this webinar with you guys, and hopefully this is going to be an empowering webinar to share and showcase some of our technology and ways that we can improve mental health outcomes for primary care patients, or for all patients in any care setting. So with that, we're going to jump to some slides. We're going to try to focus this more on the actual product and solution. So we'll try to blow through some slides real quick just to get going. Okay. Just very quick disclosures. We've done a lot of clinical research. Okay. Obviously, there's some common names here and names that we've already, obviously the NDAs have expired for some of these, so we can actually say, because they're kind of old, but we've done a ton of, we've been the measuring stick for pharma in phase 2 and phase 3 studies for a very long time to release a lot of these medications to market, both in adults and children and adolescents. The learning objectives today are really to review, just how frontline care is managing mental health, what's the current status, discuss a little bit about care navigation, coordination, integrated care, then go into, Clinicom and how we can address some of these issues that are seen in these settings and dive into some case studies. I don't need to inform you guys, everybody out there in the field knows that mental health is in its own pandemic right now. There's, mental health cases around the world have been increasing steadily. Suicide has become one of the leading causes of death in the United States. 1 in 5 patients walking into a primary care setting are going to have some associated mental health conditions or illnesses. So it's an important thing to screen for in all patients. And if, you speak to more than 5 patients in a row and didn't bring up anybody's mental health, we missed something. So hopefully today you won't have to think about that too much, and I can show you a tool to help you process that. It's important to note also that this unlike other health conditions, mental health touches the whole life cycle of a person, including their employers, their family, the education system, all the way down to your insurance company. So there's a lot of issues going on, especially in primary care with insufficient mental health screenings, and really just the issues of treating mental health in a community setting with limited resources as far as access to psychiatry. 60% of counties in the United States don't have a psychiatrist. It's a psychiatrist desert out there. You're more likely to run into a librarian than you are a psychiatrist. So our goal at Clinicom is to empower providers in any care settings to make better decisions in care navigation and clinical decision making. It's important to note that, mental health is a very expensive part of healthcare. If you have cancer, it's very expensive. The treatments are very expensive, but it's a relatively short duration. If you have schizophrenia, it's probably for the rest of your life. So Medicaid spending, a good chunk of it is spent on mental health care. So reducing this expense and making it more efficient, more effective, getting the right treatments in the patient's hands in a more timely basis. In mental health care, we see a lot of patients having to try several things to get it right. And there's a lot of waste in the system from that trial and error. Something that a lot of people don't want to discuss and is kind of hidden under the rug a little bit is the really alarming rates of misdiagnosis in mental health in the primary care setting. So primary care docs tend to misdiagnose mental health to a certain degree, ranging from about 65.9% to 92%, depending on the condition. 80% of antidepressants in the United States are prescribed by primary care physicians. And, it's important, if the majority of these medicines are coming out of primary care, that the diagnosis be accurate. Just recently, we saw a bipolar patient that had been put on an SSRI and probably making them manic. So I know a lot of primary care docs are hesitant, or at least more cautious, to screen out for other comorbidities, but time is limited. Time is the limiting factor. Every primary care physician and caregiver, nurse practitioner, and otherwise would love to have 2 or 3 hours with every patient. But in the 15-minute model, it's very difficult to understand somebody's entire mental health journey, and patients feel a little bit rushed out of the room and not having the quality time to really express what's going on with them. And clinicians would love to have the ability to pry open Pandora's box and get to other comorbidities and what's going on. But due to time constraints, it's nearly impossible most of the time. So what happens is you end the cycle of patients in and out, trying new things, throwing darts at dartboards. And we're trying to present a solution today to put an end to that. The impact of the current, situation in mental health and primary care is, patients feel unheard. There's significant impact on families and caregivers. Clinicians are frustrated and feel unempowered. Patients are needlessly suffering and trying the wrong medications. Insurance companies are wasting millions of dollars. It's one of the most significant wastes in our healthcare system. In the ideal situation, we'd love everybody to be able to afford and be able to execute an integrated primary care mental health integration plan, where you're coordinating with mental health caregivers and your regional and your integrated therapists. But this is not a reality for most people, and it's very difficult to execute. Sometimes it's hard to contract for these things. The contracting may be new, and so it might just, the fear of a new event. The point is that this is still not for not available to everybody, and it is an ideal situation. And so we're trying to present today is how can you bridge the gap if you can't or have not been able to get to all the way to integrated mental health care in your primary care setting. Care coordination and care collaboration are also very interesting models, and it can also become a very slippery slope. We've seen in some primary care settings where care navigators, care managers, care collaborators, if you will, are basically being, the patient load is being moved from the primary care doc for mental health patients to a care manager, and they're feeling inundated, unempowered. They don't have the tools, and they're even less, empowered as far as the education to diagnose these conditions. And so it's really just a slippery slope of just passing the buck in some cases. So the issues and the challenges there have been, huge patient backlogs, the availability of hiring the care team. And then most of them are still using point solutions and kind of insensitive tools to assess a limited number of conditions. So you might see typical PHQ-9, GAD-7s going out, a couple light screeners for certain point solutions. And we feel like that model's very broken, and we'll showcase why here in a minute. So we need better care navigation tools to empower these teams and really, try to get them a tool in their hands that can really make their lives a lot easier. And that's hopefully what we're going to present for you today. So Clinicom is a very effective tool. It's been in development since 2003. So we're one of the first digital mental health tools in existence. We were in stealth mode for over a decade, dialing in our software. It's very different than some of the EMR assessments and companies out there that may be screening for a handful of conditions. Handing somebody a PHQ-9 and a GAD-7 to screen for, 2, 3, 4 things is pretty simple to do. The problem becomes once you start asking a bunch of what we call stacked assessments, patients feel that it's tone deaf and they quit answering. So the magic sauce of Clinicom is the ability to screen and assess for 80 DSM conditions by the DSM criteria and those standards in an adaptive, intuitive way that is basically asks the right questions of the right patients in the most efficient time possible. So, we are able to integrate Clinicom into most EMRs, telemed platforms, digital DTX tools in a white label way, EDCs. It's very, very safe and encrypted, twice the level of most banks. So, when patients get a little intro video and they're told how safe the information they're providing is and how it's encrypted and separated, and their PHI is separated in different databases from the questions they answer. But it's also the only comprehensive mental health platform that can assess for 80 conditions from a single adaptive machine learning assessment. So instead of having to rely on a clinician who may be misdiagnosing more than half the time, and if you provide a clinician just a library of digital tools and say, hey, point solutions, hey doc, pick and choose, send what you think. If they're getting the diagnosis wrong half the time, they're probably sending the wrong tool, the wrong tools half the time. And so the solution we're offering is, hey, all you need to know is the patient's email and phone number. We'll figure it out. We'll adaptively triage them through the algorithms and present you a report so that your patients feel understood. All right. The other thing to point out about Clinicom is that it's really affordable and easy to execute. It can be executed in any care setting. So it doesn't necessarily have to be primary care, but it could be upstream from you in a school or in an outpatient center or a pediatrician, university. So it's basically site agnostic and can be adapted to any care setting. And we have, we could also pull modules if you want to lighten the load and make it screen for fewer conditions or have a easier tool. So it's very adaptable to the care setting as well. Clinicom's as easy as sending a link to a patient via email or text message. They complete an assessment at their own time on their couch with no time constraints. So this whole data capture is moved from your office, your waiting room, to when the patient calls and schedules an appointment. And that's really important because patients want to feel heard and understood, and they don't want to, if they have to wait X amount of time to be seen, they can do this in your lobby, or they can do this from home before the visit or after your visit and review it upon return. Basically, the beauty of it is they can start or stop at will, and it saves their place in the algorithms. It's adaptive, so it's listening. It adjusts the questions to the reporter. So if it's a child, they will know and adjust the questions accordingly. If you're reporting first person or third person, the questions adapt to the reporter and the age of the reporter. Then it automatically generates a great report for you to review, and then you can accept and reject those diagnoses suggestions and move on to tracking with standardized follow-ups that are suggested based on your accepting or rejecting of the suggestions. So it's a lot of automation, a lot of clinical documentation automation to help clinicians, spend less time typing and more time fixing problems with patients. So again, there's 255 algorithms here. We also have a huge library of standardized assessments. We cover social determinants of health. We do not diagnose anything. We are an assessment tool, and we allow the clinicians to review and then accept, reject, or rule out through our patented process. We also, that process of accepting or rejecting, kind of helps set up your follow-up. So that's semi-automated for you as well. And then we have, huge data tables and population health data statistics and graphing on an individual patient basis, but also on a cohort level basis that we can review. So there's a lot of utility here for Clinicom. Okay. There's a lot of other domains and areas within the report that we capture. So we're not just capturing just the mental health. We're capturing a lot of the stuff you might be capturing on your intake. We can feed that directly into your EMR as well in an intake process. Okay. We're also capturing some deeper biopsychosocial domains. So things like employment, leisure, quality of life, social determinants, and the history, psychiatric history, past medical history, family history is all very important when looking at mental health, and especially if some of the cases we'll review, looking at the family history, see if there's any genetic preloading or any family history of other conditions that may be cues to dive deeper. And also just, understanding somebody's biopsychosocial status in their job and their legal status, real important to understanding the causality and comorbidities. Thank you. So there's tremendous value for for patients in Clinicom. I mean, we have so many case studies and patient testimonials. I'm happy for you guys to go to a website and check them out. But there is just, the feeling from patients that you got to ask all the right questions You didn't feel rushed out of a room. You feel heard and understood. You were able to tell your whole story. And as one veteran put it to me is, I'll never have to unpack Pandora's box for anybody ever again. So you have this portable mental health report that they can take with them to various clinicians, print it out, save it. They have full data portability to their report. Clinician, upon clinician release, obviously you have to release it to them. And it really makes patients feel like they're getting top-notch care. Also, for patients, it avoids a lot of having to try the wrong medications or walking into a room and getting a bunch of subjective questions. Most of the question gathering happens before, and so the actual treatment time is spent less diving down rabbit holes and more actually assessing the issue and fixing the problem, which is particularly important in primary care where time is very limited. Clinicians do not have the time to sit down and poke through rabbit holes. And I've had clinicians tell me, hey, I got a couple ADHD cases tomorrow, I'm dreading it. Or if I have, this bipolar patient coming in, I don't know what to do. And so, this care navigation part of Clinicom is really important. It's really just empowering for clinicians to make sure that we didn't forget anything or miss anything, understanding which conditions are the most important, which ones are the most severe by severity or CGI, and really just going through in a quick way to make sure the patient's made whole and taken care of, and making your clinical documentation a lot easier for you. In comparison, Clinicom to some of the other tools out there, what stands out is our deep knowledge of mental health research for pharma over 20 years. We've been the measuring stick and the trusted measuring stick. Pharma does not trust you with their sensitive IP unless you have a lot of integrity in measurement. Also, the ability to screen for 80 conditions from one adaptive short assessment. So Clinicom can be as short as 10, 15 minutes if there's nothing wrong, to average of 28 minutes. And it could be a little bit longer if you have a lot of comorbidities and need the time. It's adaptive. So it basically adjusts itself and tailors itself to each patient. And in one assessment, without having to pick and choose what to send, you're screening for 80 DSM conditions. Unlike our competition, which basically are screening for a handful of conditions in one assessment and then have a library of point solutions to offer you. I can't say enough about how important it is not to drop the ball when you have an Asperger patient or somebody with learning disabilities or Tourette's or whatever the condition may be, or bulimia. Not looking is also a problem, right? And especially if you're relying on insensitive tools like a PHQ-9, who the FDA would not even allow that tool or that measurement to be allowed into a primary endpoint for an FDA study, being used widely in digital health. So it's a little alarming to us. We actually do capture the PHQ-9 and some other measurements as a control arm for some studies that we'll have coming out in the future to show kind of the insensitivity of those tools versus Clinicom. The takeaway here is, it's pretty easy to screen for 4 or 5 things: sleep, insomnia, substance abuse, and depression, anxiety. But there's so much more to the human complexity and so much more going on with people that it's almost a disservice to people to just screen for 2 or 3 things, or even a handful of things. And the complexity of getting past, you'll notice here, some of our competition is stuck at a dozen or so conditions. And the reason for that is we were stuck there too back in 2005, 2008. It's the differences between launching a bottle rocket and launching a Atlas V rocket to Mars and landing it back safely, and the level of complexity to be able to assess 80 conditions. It's really never been done before anywhere in medicine. So this is done by 250 proprietary algorithms interwoven to each other. It asks the right questions to the right patients. It stops asking questions if it starts going down the wrong rabbit holes. Yeah, an example I give is if you're hit in the head in the military, it would deploy the TBI questionnaire, our military deployment questionnaire, and aggression and some other things. So it's case dependent and it's tailored to the patient. And we've studied this on for decades. Okay. So there's some stats you can find on our homepage, just clinicom.com. We have a 96% overall completion rate. As far as the engagement rates, tremendous. You're going to uncover a tremendous amount more comorbidities. It's going to give your emergency rooms or primary care office resources back some time. We know in an emergency department, a SMI case for schizophrenia, for example, can really bog down a nurse's time for a couple hours. And so we know that with Clinicom, we can really move that to a waiting room and a tablet and really empower that clinician with a ton of information in just minutes. So there's a lot of stats you can go through. Obviously, we are HIPAA compliant, GDPR. We have Part 11 compliance for data gathering with the FDA standard. Our chief technology officer actually helped found the life science division at Microsoft. And so, we've been working with IBM on the cloud there for almost 15 or 16 years. So, end-to-end encryption, encryption in motion and at rest, very secure, very tight, life science grade infrastructure coding. So this is definitely not vaporware. In the process of going through the assessment and going through the case studies, I'd love to share with you guys some links. If you decide you want to get a free trial or start onboarding, we'll go through this at the end. But I'm happy to share. I think we're at the workflow for Clinicom is also very easy, very little to do. Schedulers literally enter an email, phone number, hit send. Clinicians are literally reviewing and accepting and rejecting right within the report. And there's a billing module that actually shows your billing department what applicable codes per the time spent by the clinician and the patient you meet the standard for, and generates a report for you. So this is all very easy and a very light lift. A lot of automations. Okay, so I think we can dive in. Move forward, Marcus. Thank you. All right, so we're going to go review some case studies on Clinicom. And Marcus, let me know when I'm sharing my screen. Let me know if you can see the Clinicom dashboard.
Yep, you're all set to go.
Thank you. So this is a typical Clinicom dashboard. Typically, when you get yours, it's going to be white labeled with your logo. So anywhere you see Clinicom or the Clinicom word, imagine your company, your logo, your colors. So basically, Clinicom is as easy to send in a primary care setting as in any other setting. Literally, you just select which comprehensive assessment to give. One has a lot more social determinants of health and biopsychosocial information, and that's our Clinicom Pro. They both, Clinicom and Clinicom Pro, screen for 80 conditions by DSM criteria. So you can simply just enter a email or a phone number and hit send, and that's it. You're going to get a 94, 95% completion rate. There's going to be a lot of baked-in science behind that completion rate, a reminder frequency, automated soft touch messages, an intro video explaining them to what they're getting themselves into and what they're going to have to commit to. You can also add a patient right here in front of, if you have if this is a tablet and we're in a waiting room, I can literally hit the Clinicom button and just start the assessment right here and hand the tablet over to the patient. They would not be able to click backwards and see any other information once you hit that button. But when to look for a patient once the assessment's completed, and remember, you don't have to worry or chase down the patient for completion. This is all done for you. To the great majority of 94 to 96%, depending on the setting. And you'll end up with a very detailed report on any patient. So today I'd like to start with just looking over a bipolar patient, because I know this is a complex SMI case, and a lot of primary care docs get a little bit challenged when they feel like there might be some other issues going on other than depression, and that can be very challenging. So this is a good case to exemplify why this is an important topic and why how Clinicom helps triage the patient. The first thing you'll notice on the assessment results page, we call it our summary page, are the conditions that Clinicom flagged for this particular patient rated by severity. So you'll see here there's bipolar 1, a manic episode, some persistent depression, some insomnia, some learning disabilities, and they're all triaged by severity. You'll also see some standardized assessments that we call our control arm. And that control arm for your location can be anything out of our 200 assessments that you want it to be. We just take some standardized measurements at the beginning from everybody and then periodically throughout, so you have some standard measurements. And also it helps feed some of our studies that we're putting out. On the assessment summary, you can also see the improvement over time over various follow-ups and the changes from baseline and the changes from current visit. So this is really helpful just in a 2-second view to see how your patient's doing. You can also graph this out and review this with the patient over time, so you can see, what symptoms are getting better and focus in on certain symptoms and take some others out of the assessment and focus in where you want to focus. You can also look at the progress of the patient over time if you want to focus in on, let's say, how their bipolar disorder is doing and versus the last manic episode. You can compare and contrast, review medications, and really dive in a little deeper. So the main point I want to make is that everybody's summary page is different. So depending on the conditions you flag and the algorithms that were triggered, you are going to have a different presentation here for every patient. So there's less guesswork for the clinician. You kind of know where to go first. There is also a narrative. So Clinicom generates a a narrative. Excuse me, I click the follow-up button. Back up. Pardon me. There is a narrative button that will generate a narrative that is that is also fed from the symptoms the patient reported. So it's not an EMR template as sorts. It is literally pulling from the report the details and specific symptoms that the patient, per the criteria was reporting, and annotates that for you. So that's pretty powerful. The meat and potatoes of Clinicom is the Clinicom report. So let's open one up and see what that looks like. So at the top of the report, you'll see the report type, the patient information, some quality measurements of how long it took compared to any other report or similar. You'll see the medications the patient started. So you'll see that this patient's tried some SSRIs in the past for several years. You'll see that the clinician has accepted certain conditions and is ruling out some others. And you'll see our summary again of the most important conditions to review. This is great for triaging and to understand, is there a little bit going on here? Is this simple depression and I can treat this here in my primary care setting? Or is this a more significant case that needs to be referred out? A lot of times it takes several visits and a lot of explanation to try to get through that. And with Clinicom, any nurse practitioner, care coordinator, care navigator, clinician can in an instant understand the complexity of the case and where they may need to go for services. So for this particular patient, let's dive a little deeper into the depression and the mania. So we'll go to, we'll clip that section, and Clinicom lets you drive to a certain section of the assessment here at the bottom. You can scroll through and see it is quite a deep report on this patient. And we'll jump into depression. And you'll see here at the top of the section, it actually tells you how the CGI of the potential condition, and review. You can review with the patient on a telemedicine visit, or print this out the PDF and review the symptoms and validate the symptoms with the patient right in front of you. The power of this also is that instead of typing all this, I can literally just clip this to my clipboard and take this into my EMR in just 2 clicks. We can API this into your EMR directly through our APIs and just feed the system so you can focus on your patient. And in a non-integrated way, we have some tools to make it easy and light to use as well. You can also see that this patient did not have generalized anxiety disorder by the algorithm. So it didn't keep asking a bunch of questions about anxiety. So it's adapting to the patient. In regards to their mania and their manic symptoms, they're pretty severe and significant. So it did rate the mania and reviewed some of those symptoms, and you can review those with the patient, validate them, and then here at the bottom of your report, right within the report in any setting tablet, you can then accept, reject the diagnosis. So Clinicom, you can accept, reject, or rule it out. And that is really a powerful tool to not only feedback and educate our system, which we've been training for nearly 2 decades, but also a powerful tool to let you control and direct the severity. Were they underreporting, overreporting? Did you want to make a note about, for further evaluate this? You can set it as rule out and not be sure. The point of this is it actually has a function. It not only educates the algorithms and makes them more refined, and this process is patented. It does also, help set up your follow-ups. So as we go through, we'll check some of that out. If you ever have a question about the actual question the patient was asked for a particular line, the actual questions themselves to the patients is in the question mark button. So you'll be able to scroll down and look at the actual questions that the patients were asked, and not just the summary synopsis here, because those titles are just summaries, not the actual detailed verbiage. And those questions change depending on the reporter. So if you open up one of those boxes, it's not necessarily all our questions for that field. It's just all our questions for that field for that type of reporter and that age group, etc. So the different sections could be different lengths depending on how they answered. So if they could answer a couple questions and it's no, 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 it's going to stop asking. So it's not going to ask you 50 more schizophrenia questions if you don't meet the criteria. The important thing to note is this is all based on the criteria in the manual. So We literally copyrighted first person, third person, and pediatric versions of questions that align to the criteria requested in the manual that everybody's trained for psychiatry. And so that's an important distinction. The other important distinction is, for this particular patient, is looking at their history, right? And so we're seeing some depression, we're seeing some mania, and at the very top of the report, we saw that they were on an SSRI. And so this happens every day in primary care, right? You have bipolar patients typically present depressed. You may not see them in a manic episode. You may not be able to spot the manic episode. It may have been a while ago. And so it's not untypical, and it's sad to hear that sometimes we find bipolar patients taking the wrong medications. Some SSRIs can make bipolar patients manic and make them worse. So just because somebody flags high on a PHQ-9 doesn't necessarily mean it's just depression. What if it's bipolar disorder? So you can see here, this patient flagged 11 out of PHQ-9, and if you didn't have Clinicom, you probably would have just prescribed another SSRI. So the power of Clinicom is really making sure you don't miss those corners and those comorbidities, understanding the depth and breadth of comorbid conditions, understanding what else is affecting, contributing to this patient's case, and flagging any sensitive topics. That's an important distinction. One of the first starting points of Clinicom's report is the chief complaints. So you get a really detailed understanding of the first, primary, and secondary complaints. We have several versions of this report, so we can tailor this down, showing you guys a very expanded version for the deep dive Clinicom Pro. But there's other variants. So if we have some care settings for primary care where they trim it down, they're looking for 20, 25 things tops, and they want it done in 10, 15 minutes. So we can do that and just literally unplug wires for you, and it's just the same setting, the same tool, and our client success team can dial that in for you. Another interesting case, and you might see in primary care a lot, is a teenager or a depressed child, and they may be presenting with their mom or dad, and typically you get patient report from parent. So Clinicom is we have a special tool that we call the 360 tool. So we don't charge any extra for it, but if Clinicom realizes that the reporter or the patient themselves being reported on is between 12 and 19 years of age, it will prompt the parent who's filling out the Clinicom if they'd like to send a link for their teenager to their phone, the teenager's phone, so that they can complete their own version of Clinicom. And what we get from this is shockingly revealing most of the time. We can find, that mom and dad, even with their best intentions, many times don't have insight into the teenager's lives and the details. Once the teenager sees our video and understands that this is a safe place to be themselves, you have some alarming things happening. So this is a real patient, de-identified, obviously. All data has been de-identified. But one of the things to kind of point out here is, this patient scored an 8 out of 27 on their personal PHQ-9. Mom's PHQ-9 was 2 out of 27. If you would have seen just doing a PHQ-9 in primary care, you would have missed this patient. Look at their suicide warning, right? It's pretty high, pretty significant. Their irritability index, they have chronic insomnia. They have some OCD going on. So what else is contributing? And so without Clinicom, this patient probably would have been missed. The other thing to mention here, if we dive into the report, is, this patient has some, and this report, you can see at the very top, took 41 minutes. This was a complex case as mom and child contributed to the time. And you have here the medications, but, in the family history section, this patient actually has some other things going on, right? So, you'll see an irritability index. So Clinicom asks the right questions of the right patients. It also captures deep dive biopsychosocial information. So for mother in this report, you can see here at the very bottom, if we jump to the bottom of her Clinicom Pro, everything from allergies down, from conception, pregnancy, sexual development, early temperament, family histories. So you can look in to see here their support system, even some of the biopsychosocial stuff, social determinants of health, education, leisure, activities. So the Clinicom Pro does dive deeper. So if you have more time with your patient, and if it's a different care setting, or if you're a care navigator and you're looking for that information to pass along to a therapist or somebody else, really insightful, really easy to use. We have schools that use this across many campuses. I know Syracuse University has been using this across 58 campuses for a good long time now, and others. And so, the care, it's agnostic to the care setting. The other thing to note is when you accept and reject a diagnosis within the report, it will also kind of set up our follow-up. So let me do that real quick for you guys and see what that looks like here. You can see here there's some accept or reject buttons here, and they go away once you accept, and you can modify that if you need to. But the follow-ups are amazing and easy to create. So based on the accepted criteria, you can easily add a follow-up to any patient. Because this clinician has accepted insomnia, GAD, and we have our control arm in here, the system has auto-populated a possible follow-up for you. So you don't have to really think too far. You can create the follow-up, repeat it. Let's say we want to do it 4 times. We want to do it every 9 weeks, whatever the cadence you want. You have an entire year on a patient to monitor them every day, every minute, with Clinicom. We do not charge you for multiple assessments. You're getting a patient for an entire year to measure them as much and frequently as you want. So if it's IOP, SUD case, primary care, it does not matter. You can set whatever cadence and frequency you want, and we'll monitor the patient as many times as you want during that year. So you just hit send, and they automatically at the right time will get their notification in their portal and fill it out. If you want to add scales to the follow-ups, you can craft your own by just clicking other, that's a clinician-facing assessment. Let me remove that. You can add other patient-facing assessments. You can add other standardized scales. Let's say you want to measure for conduct disorder. You were, told that you probably needed to evaluate them for some other things. You can select whatever you'd like. You can also add the informational questionnaires a la carte. So if you send a Clinicom instead of Clinicom Pro the first time, you can always just add the social determinants of health and hit send. It's that easy. And you can also send this to a third party. So through the patient gets the invite and forwards it to whoever they allow to make it HIPAA compliant. But you could forward this invitation to coach, mom, teacher, and again, get that 360 report that you wanted on your patient. And if it's been a year or two and you haven't seen the patient in a while, you can just send them a whole new Clinicom and triage them for another 80 conditions if you haven't seen them in a few years. The other beautiful part of Clinicom is if you don't want all this, if this is too much for primary care and you just want to assess for a handful of things, maybe 1 or 2 things, it doesn't matter. You can quickly invite a patient to just do one assessment, one of anything you'd like. You can come in and do a custom Clinicom assessment and say, hey, I just want to screen this patient. I think they're gambling a lot and I think they may have autism. Hit send, done, right? So Clinicom can be as big or as small as you need. It fits all care settings, any use case, multiple users. There's on-demand training. We provide, remote live training as well. Clinicom is available in multiple languages, so I can send this in Portuguese and read it back in English, send it to somebody in Spanish and read it back in English or Portuguese. We have various languages to choose from. Very easy to add staff, and then they are put through an automated training sequence. It's a pretty powerful tool for any care setting.
And Ignacio, I'm gonna pause you right there and just ask one question that we have from the stream that we're kind of in that section. So I'm going to show this question. In a primary care setting, we encounter a wide range of mental health conditions. Can Clinicom automatically assess a broad spectrum of these conditions for all of our patients at once?
Yeah, that's the beauty of Clinicom, right? So if you told us, hey, I want to screen all of New York City and triage them by who's suicidal, who's depressed, who's TBI, we could do it in 48 hours. It's amazing to say it, but we have the technology, the power, the bandwidth, and the scalability to do so. So if you gave us your entire list of patients and said, screen them, or we have, if you say, hey, give me an entire list of emails and phone numbers for a school, and they're opted in, we can screen them in a day. Imagine the time it would take to hire a psychiatrist, the money it would take to hire a psychiatrist just to individually screen all those people, provide a report instantaneously within 20, instantaneously on your desk. It's nearly impossible. So it's got infinite scale. And so what we're trying to do is empower the middle, empower digital health companies, telemedicine companies, primary care, anybody contacting mental health patients to be able to care navigate them to the right level and cost of care.
Yeah, and so one of the unique benefits of Clinicom is rather than having to one-off enter in every single patient and all of their information, uh, Clinicom can actually have one link that you email out to your entire population of patients, and they can take that one link and go from there and register. So it's very efficient in terms of the setup and onboarding of your entire patient population.
So what Marcus is pointing to is our invite instructions. So you can manually invite through our portal. You can tie Clinicom to your EMR through API, where as soon as you create the patient in the system, it automatically sends it. Or you can have an email that goes out through your Salesforce or your CRM or EMR and use this link and create a button, and anybody who clicks that will go into your portal specifically. You could add multiple sites, multiple locations. We're set up to scale. We have large enterprise clients. And so there's also some huge value to the statistical side of this for care navigation, sorry, I have to log out of it. Might let me. Let's see. I think I have to log out of this particular account to get to stats. Probably. Let me log out. So that's a demo site. So in essence, Clinicom is available to any primary care provider, but the administrators for primary care or any care navigation organization, even telemed, the data for value-based care and metric-based care is so hard to come by. It's so inefficient to gather the information. You have to unite multiple systems. You have to ask your IT department to pull reports. With Clinicom, the beauty of our system is the statistics and every data point we're collecting is already captured in that FDA Part 11 compliant manner. So you can rely on the data, but most importantly, it's like having a live phase 3B study going 24/7. So real outcomes, real measurements. If you want to know how Prozac's doing in 16-year-old females in Wichita, we can give you the answer, right? The statistics that you'll get for your standard account will show you distribution of comorbidities. You'll be able to see your average anything score over time, how you're doing with your measurements over time, which is really helpful for value-based care analysis and payments, which, this is empowering you to be able to do those things and get into those kind of value-based care contracts, which right now, some of our primary care doctors are saying it's very hard for them to execute the plan with the current systems they have.
Again, actually, we do have a question based on that that I can share. So the question is, what are the financial implications of implementing Clinicom in a primary care practice? How does it align with value-based care models and affect reimbursement processes?
Sure. So on the reimbursement side, we're capturing the data that you're trying to present for those payments, right? So one, we're capturing all that data autonomously for you. You don't have to think about it. You have the data, it's there for you. So on the capturing, presenting of the data side, it's definitely very powerful. On the other side of things, to help you actually execute those value-based care programs and the cost associated with it, typically Clinicom, and let me stop sharing, Marcus, if you can go to towards our end of our discussion slide, and maybe we can present that. 33, I think, or 34. So as he's pulling that up, the financial model is very easy, and this is what we love. Unlike a lot of the assessment companies out there, there you go, Marcus. It is only $12 per patient. Our company's mission is equity and access for all, and we mean that. So it's not just trying to make as much money as we can. We care about providing equity and access to all countries, all persons, and everybody deserves to be able to tell their whole mental health story. So for you as a clinician, it's $12 for that patient for an entire year of his unlimited measurements. Measure whatever you want as often as you want for that patient for the entire year. The reimbursement side of this, with giving, if you go to Clinicom/onboarding, there'll be a link there for our billing guide. For an MD, that can range from $60 to $120 on the reimbursement side. So you're going to 5 to 10x your expenditure. You're going to get the system for free. We're not going to charge anything to set it up, to activate you, to train you, to support you. You're going to run through these in a month and do what you're going to do. You're going to get reimbursement. And by the end of the second month, you'll get your first bill only for the 30 to 60 day period. And you obviously get the first period for free. And so it's no upfront cost and no risk to you to try. You can go and it's covered for most health insurances. Next. It's also really easy for you to sign up. You can go to clinicom.com and just click our free trial link. Once you sign up, our client success team would be right with you, and within minutes, try to get you scheduled. You can launch it on your own or with our support. The support is free. The training is free. The activation is free. There's no upfront cost whatsoever. And you can start training immediately. It takes 3 to 4 minutes to get started. It'll take you a commitment of about 30 minutes as a clinician to really train on the onboarding link. Your scheduler will take about 15 minutes to train, your billing person about 15 minutes, and you're live and at scale. There's some links on the page that you guys can check out, /free trial 7. That will let us know you came from this webinar and that obviously you get your free trial. It's a 30-day free trial. That free trial is going to 14 days for the open market. So use that link and you'll get your 30-day free trial. On the /onboarding link, you'll see a way to schedule some time with our client success team that will white glove service you and also help you come on board. You'll see links to our clinical guide, training videos, billing guides. So support is a big deal for us in multiple languages. We want to make sure that we're always available to you in platform, out of platform, and around. Our goal is to really empower you guys with the latest and greatest technology, and it's constantly evolving. With that, I appreciate the time everybody's given, and hope that you guys can explore any solutions to help you along the mental health journey for primary care. I know it's challenging for primary care clinicians, feeling rushed, always feeling like you're behind on time, and we'd love to kind of take that stress away and make sure, at least for your mental health patients, the clinical documentation burdens are taken care of for you. And if you just want to execute annual screenings, right, this would be a great thing we can automate for you on a calendar. So you don't have to worry about collecting that information. And there's also alerts in the system. So if you said, hey, set my alerts for anybody suicide 5 or greater or aggression higher than this number, you give us your threshold amounts and we can actually send SMS and email alerts to whoever you want if somebody within the triage reaches a threshold. So a lot of features we didn't discuss. Happy to dive deeper with anybody if they'd like, and appreciate your time and you've given us to share Clinicom with you.
All right. And with that, we'll close out this webinar. Make sure that you visit clinicom.com for all the information about Clinicom, our platform, testimonials. We've got a demo on demand. We've got a lot going on there. So please give it your attention, clinicom.com. And with that, we'd like to thank you, and we'll